Hello, everybody. I'm Paul Ryden. What's the first thing you think of when you wake up in the morning with a headache? Did I have too much salt last night? Did I drink too much alcohol without hydrating? Or worst case scenario, do I have a brain tumor? Well, our guest today, Dr. Egilius Spierings, has undoubtedly heard all these questions before and is here with some answers from his book entitled Headaches: Why You Have Them, What You Can Do About Them. Dr. Spierings, great to have you with us. I guess you have heard some of those questions, right?
Yes, thank you very much. Yes, I've heard all of those questions and a lot more than those. Yes, of different kinds.
Well, according to your book, headaches are pretty much a part of life as much as fatigue is. We all get them, right?
Yes, so I do think headache is part of life, and um, not too many people wonder why we have headaches to begin with. But that has kind of been a question I have been um, dealing with for the half a century that I've been involved in this particular area. And based on my multiple interactions with patients, I've kind of come to the conclusion that it is strongly related to fatigue. I call it a secondary symptom to fatigue. If you ignore fatigue, I think headache is the symptom that, or the complaint that will emerge and will further force you to take a step back. So I think there is a biological function to having headache, but those headaches would really be of a mild intensity and generally relieved with rest, relaxation, over-the-counter medications.
So, what types of headaches that people suffer from that you address in your books? I know there are all sorts of different headaches, some extreme, some not so extreme, some are harmless, but what kind of headaches are there?
So undoubtedly, the most common type of headache is what we would call a tension headache.
Mm.
In general, people would refer to that as a regular headache, an ordinary headache, a headache that you may have, let's say, in the late afternoon from fatigue or maybe from eye strain. Some rest, relaxation, and over-the-counter medication will take care of that. Even when those kind of headaches occur frequently, and about 2 or 3% of the population has those kind of headaches on a daily or almost daily basis. But even if they occur frequently, people tend not to seek medical consultation, which is not always a good idea, especially when you have them frequently, because there may be another condition underlying that, a medical condition underlying that. But what really drives headache consultation in general is headache intensity. And then you're really looking at a condition that we refer to as migraine. And we know as such, it's a very common condition. It affects about 15% of the population, 1 out of 7 people. And that is a condition, I'd like to refer to it as a headache amplifier, a condition that is genetic, it's inherited, and it amplifies your ordinary, regular headache into a very bad headache that will affect your body as a whole, very often disables you, and also is generally not responsive to the medications that we can buy for headache or migraine over the counter, certainly in terms of getting, full relief of the headache. They may mitigate the headache a little bit, may take away the nausea that you may have with those headaches, but they will not relieve those headaches.
Yeah, I've been very fortunate. I've never had a migraine, but I know that there are people and friends of mine who have them. Is there one particular way to get rid of a migraine, or are they all different?
I would, migraine headaches are migraine headaches. And I think the biggest problem is that very often people don't recognize the fact that they have migraine. They may say, gee, I suffer from bad tension headaches or um, bad sinus headaches, or maybe when I was younger, I had bad hangover headaches. That's why I don't drink alcohol any longer. But these conditions don't exist. There's no such thing as a bad tension headache or a bad sinus headache or a bad hangover headache. These are all migraine headaches um, that have amplified those headaches into bad headaches. And we have very good medications that we've developed over the last 3, 4 decades to treat those headaches. We have triptans, medications that have been around for over 3 decades. We have a new class of medications called GPANs. These are specific migraine medications that also have the potency of relieving those very bad headaches to the full extent where people struggle with over-the-counter medications and can't get any relief from those.
Well, as a pharmacologist, you've had a hand in developing migraine medications. What role does medication play in the treatment of headaches versus home remedies? If somebody were to have a migraine or a severe headache of some sort, are there home remedies they can do without having to resort to medication? And what role does that
Yeah,
play?
not really. As I said earlier, these are the kind of headaches that your over-the-counter medications, even those with a specific migraine label, do not relieve to the full extent. Again, they may give you some benefit, but certainly don't relieve it to the full extent. For that, you really need prescription medications. And I would say that this is what we call abortive or acute treatment. When you have a bad headache, you want to take something to get relief. And the only way really to proceed there is with those prescription medications. Again, these two classes, triptans and gepants, is what I think people should focus on. And that's also one of the reasons I wrote the book. You mentioned already have a background in pharmacology, which has to do with the way medications work. I've been very much involved also in the clinical trial research related to those medications. That is the development of these anti-migraine medications. And I would say that we've developed such good tools that I think the treatment of migraine is really with medications. People struggle with all kinds of things and try to obtain relief, but I would say certainly acutely or abortively, this is what people should rely upon, these medications out of these two classes. That's really the standard of care. And these medications were specifically developed for migraine and also give you by far the best benefit.
Now, most people don't suffer from migraine. Speaking for myself, if I have a small headache, I know my body well enough to know that what's causing it. It could be that I haven't had enough caffeine, and when that's the case, I'll have a cup of coffee or I'll drink a Coke or something like that. Are there patterns that people can look for and different types of headaches?
Yes. For example, first of all, if you have severe headaches, as we talked about, migraine is really the most likely cause of that. And as I said earlier, migraine is a genetically determined and inherited condition. People are generally aware of the fact that it runs in family. Very often the mother has it, siblings may have it. Sometimes it skips a generation though, but that's relatively rare. Occasionally the father has it. That tends to be worse um, because of the fact that men do not develop migraine as easily as women do.
Hmm.
And so when they do present with migraine, they tend to have a stronger genetic burden, which they pass on to their children. And that's also where you tend to get migraine at an earlier age. There are other headache conditions. For example, cluster headache is a very particular type of headache presentation, occurs mostly in men, as opposed to migraine, which we see mostly in women. Um, but that is a rare condition for which we also have specific treatment. But again, when people have bad headaches, severe headaches, I think they should really focus on migraine as a potential diagnosis and seek specific treatment for that.
I think most people get carried away if they get a headache for any length of time. The first thing they think of, oh, I must have a brain tumor. Now, sometimes that is the case, but that's most often not the case, right?
Yes, that is a very good concern to have. Um, And I think it's also very appropriate to think about that. But fortunately, it's rare to have headaches from a neurological condition like a brain tumor. But it does generate a lot of anxiety.
Mhm.
Anxiety is bad for headaches.
Yeah.
It drives headache frequency, it drives headache occurrence, so it's important to be taken care of. And again, fortunately, also there we have had tremendous development in neurology in particular with the imaging techniques that we have, such
Right.
as computerized tomography, magnetic resonance imaging, MRI. And I think people should really, if there is a concern that they have, they should really seek medical consultation or neurological consultation in this sense and get that imaging done, if only for the purpose of reassurance. I very often will say, when I teach also, the most important reason to do a scan like that is really to reassure the patient. Reassurance is key. If you cannot reassure the patient, you cannot really move on to providing that patient with
Right.
effective treatment because you really have to take care of that concern first of all.
Yeah. Does your book get into this physiology of what happens inside the head when you have a headache? Because I know there are certain things. I know, for instance, when I was talking about the lack of caffeine, the blood vessels are constricted and the caffeine will open them up, that kind of thing. Do you get into the physiology of what goes on inside the head?
Yes, I do that in particular in chapter 7. I think that's entitled What Causes the Pain in My Head. And I do that from a historical perspective. I was trained in the diagnosis and treatment of headache I trained with John Graham, who worked himself in headache and face pain for about a half a century. And he again trained with Harold Wolff, um, who was a neurologist from New York City. He did a lot of the fundamental research, what headaches are all about, including migraine headaches. And so I describe what causes the pain in the head, especially related to migraine headache in chapter 7, very much from a historical perspective. I like history myself,
Mhm.
and so I took it upon myself to write that chapter from a historical perspective, featuring those two physicians, Harold Wolff and John Graham, who also collaborated on the research in New York City back in the 1930s. So it goes back quite a while.
What got you interested in studying headaches and face pain in the first place?
Yes, so I've really been interested in the nervous system since I was in high school.
Were you a nervous student?
So it always intrigued me. And for example, my graduation biology paper was on the function of the nervous system, not even the structure, but the function of the nervous system. And when I went to medical school, that was always in my mind, either to become a neurologist or psychiatrist, as both specialties are dealing with the brain. And then when I was a third year medical student, we go through medical school 6, 7 years in the Netherlands. So I was still a pre-med student, you could call it. Um, I used to attend symposia, especially neurological symposia, and on a migraine symposium at the faculty where I studied in Rotterdam, the medical faculty where I studied in Rotterdam, I met John Graham. He was invited as one of the speakers. And at the reception, I got to talk to him for about 45 minutes or so, a very long time at a reception with
Yeah.
a medical student with a prominent physician from the United States.
Yeah.
And at the end of that, when we all had to leave because the reception was over, he gave me his address, which I tucked away. And I thought, what can you say? But then a couple of weeks later, I got a very nice letter from him inviting me to come to the States. And that was my first trip to the United States in
Hmm.
June of 1974, after one of the meetings of the American Headache Society in Chicago. Some people came to Boston, and I stayed with him at his home and met all those prominent people.
Hmm.
And then he said, "Why don't you come back and I'll get you introduced to neurology in Boston." Neurology was very big in Boston, especially in those days. It still is, but especially in those days, it was big. And he set up a student clerkship for me at the Boston City Hospital in 1975.
Hmm.
So I came back that summer, and I always loved being here in Boston in the summer. And then he said, "Oh, now I would like you to come and study with me." So I spent in 77, I think it was, that I spent 6 weeks or so with him studying headache. And then he said I should come back for a fellowship, which I did in 81, 82.
Hmm.
And then I thought, that's it, because I was going to go into private practice. I hadn't finished my training yet by then in neurology, but I was still a couple of years away from that. But I was focused on setting up a practice in the Netherlands, in Rotterdam, in fact. Um, but then he called me one day and said, "I'm going to retire. I'd like you to put yourself up as a candidate." And I thought by myself, I I was only like in my early 30s. I hadn't even finished my training. I was just going to finish my training. I was in actual fact doing my last year in psychiatry, because apart from neurology, I also trained in psychiatry. And so he was like a grandfather to me. And of course, I couldn't say no. I have a hard time saying no in general. Couldn't say no. So I just said yes, but never thinking that anything would ever come out of it, because I thought it was kind of a far-fetched idea. There were other people, candidates for that position, who were professors, and I was hardly a neurologist.
Uh-huh.
in those days. But the board then elected that I become the director, which I did, and so I came back in 1986 and have been here ever since. So for almost 40 years.
Well, must have made a great impression on Dr. Graham, even as a young student. And your book it's pretty accessible for people. You try to make it as easy to understand as possible. What do you hope that readers will get out of your book?
What I would like people to get out of my book is empowerment. I think that's very important as a patient, empowered with knowledge. I'm a strong believer in knowledge, acquiring knowledge. I've done that my entire career. I've been a professor at Harvard and at Tufts here in Boston. And so I think information is key. And there's a lot of information around that I don't think is really all that accurate or really relevant. So I've
Mm,
really tried to boil it down to what, over the decades of practice in headache and face pain, I've found to be the most important information and put that in my book in what I hope is a very readable format and easy to understand format. So it's really empowering patients that I have as the foremost goal, writing my book. And that's also why, interesting enough, I put it in as a hard copy because I hope that people will take it with them
mm,
to a medical consultation.
good.
Because I think it's important for patients to be able to sustain or have a good dialogue with the healthcare practitioner that they're consulting and that they're knowledgeable. I've always spent a lot of time with my patients trying to educate them to the best of my abilities. And that's also kind of the verbiage that I put in the book, the same way I talk to my patients, I
Perfect.
write in my book, just trying to get them to understand what headaches are all about, what migraine is all about, because most of the patients who come for a consultation have the severe headaches
Mhm.
that generally fall under the migraine category, what treatments are available, but also very importantly, what is the standard of care and what can people or what should people expect from the treatment in terms of efficacy, but also tolerability. I think I write on a lot of occasions in my book, my tolerance to side effects is zero, zero tolerance to side effects. We have plenty of choice in terms of the medications that we've developed, and the healthcare practitioners should put in the effort to find the right medication for you, the one that you tolerate without side effects at all. And of course, there's a certain expectation with regard to the efficacy. In abortive treatment, I like patients to be fully headache relieved within 2 hours. No side effects, and that consistently. And for migraine prevention, I think at least a 50% cut in the frequency of occurrence of the migraine headache. I think these are really the expectations that people should have when they consult a healthcare practitioner for their headaches, for their migraine headaches.
All right. Well, Dr. Spierings, one last question before I go. Did you tie that bow tie yourself, or is that a clip-on?
I tie it myself. I don't like clip-on bow ties, and I feel proud that I tied it myself.
Well, that's impressive to me because I think tying a tie like that probably would give me a headache. So, Dr. Spearings, thank you so much for joining us again. The book is called Headaches: Why You Have Them, What You Can Do About Them. Dr. Spearing, thanks for joining us.
Thank you very
And,
much, Paul.
and folks, thank you for spending a few minutes with us on the Global Book Network. I'm Paul Ryden. We'll see you next time.